Hi, my name is Louise Johnson. I'm the CEO of the Victorian Assisted Reproductive Treatment Authority and also spokesperson for the Your Fertility program. I'd like to welcome you to this webinar on optimising patient fertility. Before I introduce the speakers, let me briefly tell you about the workings of the webinar. Your lines will be muted throughout the webinar, so if you have any questions or comments, and we hope you will have plenty, we encourage you to post them on the chat box in the bottom left-hand side of your screen. This webinar is only 30 minutes long, so our discussion will be brief. The most common questions will be addressed briefly at the end. If there are more unanswered questions, we will produce a question and answer information and also think about running some further webinars to answer your questions and explore the issues more closely. We're using phones so that this webinar can be recorded and our voices will be clear. We'd also ask you to complete the survey at the end of the session so we can capture your feedback. If you have trouble hearing the webinar using your speakers, you can dial in to listen by teleconference. The number and password you'll need to dial is listed in the bottom left-hand corner of this page. Please use the chat box to raise any other technical issues you have and we'll help you. Research shows that most men and women want to become parents.
Oh, good though.
And about 85% of young women indicate a desire to have at least one child. However, there's a gap between what people want and what they attain in relation to their fertility. And there are predictions that in Australia up to a quarter of women will end their fertile years childless. For some people, they're affected by social infertility. They may not have found a partner or be in a same-sex relationship and need the use of assisted reproductive treatment in order to have children. Fertility awareness is important because it can help people who want to have children sometime in the future optimise their chances. GPs can assist patients in raising awareness of fertility issues and developing a reproductive life plan that includes whether they want to have children, and if they do, the number, spacing and timing. It's important for patients to know the factors that affect fertility because these also affect pregnancy health and the health of the baby at birth and through to adulthood. GPs are in an ideal position to have opportunistic discussions with women and men about fertility and what they can do to safeguard it for the future. Whether we're working at a population level through state-based or national health promotion activities to individual care, all of us have a unique role to play. Your Fertility is a national public education program funded by both the Australian and the Victorian Departments of Health. And it aims to increase knowledge about the modifiable factors that influence fertility. This evening we've pulled together two great speakers to explore the crucial role GPs and anybody in the primary care team can play in educating patients about fertility. To examine the role that primary care providers play, we have this evening Dr. Magdalena Simonis. Magdalena is a GP, an active fellow with the RACGP, a GP examiner, and also teaches medical students at the University of Melbourne. In 2014, she was appointed the RACGP representative to Your Fertility. We also have Associate Professor Kate Stern. Kate is a fertility specialist, gynaecologist and reproductive endocrinologist. Kate is also Associate Professor of Obstetrics and Gynaecology at the University of Melbourne at the Royal Women's Hospital. Kate is the Head of the Endocrine and Metabolic Service at the Royal Women's Hospital in Melbourne and Head of Clinical Research at Melbourne IVF. Thank you both for joining. I'll now hand over to you, Magda. Magda, how does a clinician fit fertility and reproductive life plan issues into a consultation?
Thanks, Louise. That's a really important question. Well, there are multiple opportunities that the primary care provider has, and the outside of the we want to have a baby scenario, when patients come in saying, oh, you know, we want to have a baby, well, I'm ready to have a child. Outside of those scenarios, there are opportunities that we can find to raise a fertility discussion and plants the seed for further discussion and assisting the patient to develop a reproductive life plan. Opportunities such as, we're getting married or moving in together, we're going on a holiday, or there are often opportunities that you can just sneak in and ask the question if they're, interested in having children, when they're planning on having children, how many they might want to have, and whether or not they've actually discussed this themselves with their partner, and arrange a follow-up appointment, because, raising the question regarding fertility and reproductive life plans raises lots of questions which you might not have time to address at that point in time. So to provide appropriate counselling and investigations prior to specialist referral, it's important to keep this very simple, accurate at the initial discussion, and then follow through with an appointment that meets their need and their timeline. And a really simple opening question I use is, at the time of a pap smear or when a patient comes in for a gynecological checkup, by the way, are you interested in having children at any time in the future? The response could be a simple no, at which point I then would probably consider asking again in 1 to 2 years' time, depending on their circumstances if they've changed. And I treat the yes to that question and maybe as pretty much the same, because it's a good opportunity to discuss the window of opportunity based upon age and how age impacts fertility, the timing of sex, asking them what they understand about the fertility window during the menstrual cycle, informing them about the importance of weight, smoking, alcohol, drugs, whether they be illicit or other, and natural therapies. And then, of course, there are the medical aspects, their gynecological and obstetric past history, the importance of taking supplementation prenatally, not just during pregnancy, such as folic acid and iodine and vitamin D, immunising them adequately for things like rubella, pertussis, looking at mental health history, current and previous family history of mental health and genetic history such as diabetes and thalassemia, STI screening, and of course the fertility tests such as the anti-Müllerian hormone and in the case of the male partner, semen analysis. If a woman's been, if the woman has irregular cycles, I'd offer investigation at any point. If they've been trying for about 6 months and if they're more than 35, I'd investigate. And if they're trying for 4 months and they're over 38 or nearing 40 and over, I'd recommend investigating and doing particular tests such as AMH, but not over-interpreting them, of course. Now, we're going to look at a few scenarios here to just explore the opportunities that GPs have. And the first one is, the younger woman in her 20s who comes in for the pill. That's pretty straightforward. I would probably say, interested in having children at any point in your life. And, if they say yes, then I'd say, well, look, when do you think? They might say 3 or 4 years from now, so I'd offer them the chance to come in about 18 months to have the fertility preconception chat, and also engage them in the lifestyle modification discussion. It's important to sort of use very positive opening comments such as, age can impact fertility. Most women think that, late 30s and early 40s are safe to start having a baby, but in fact, age has an impact on fertility, and it's better starting earlier rather than later. So, if the patient in the discussion or in the consultation is 38 years old and says to me, "Oh, I'd love to, but I haven't met the right partner yet," then I would ask specifically, how they felt about not having children ever. And if that was an issue for them, I'd then mention the egg freezing option. And although single parenting is not the ideal, it is worth knowing that eggs are better younger, not older. And I'd offer her the opportunity to think about this and come back to discuss it and contemplate whether or not she was interested in having a baby on her own. Another scenario would be the 35-year-old woman who has a 45-year-old male partner whose response to the question was, oh, I want to, but my partner isn't too fast. That's not an uncommon response I get. And I then, again, take the opportunity to inform her that, having a discussion with a partner based upon the fact that I'm giving her regarding women over the age of 35 and even men over the age of 45 have declining ease of conception. So I encourage her to bring him in for a chat if he, needs or wants more information. And also take the opportunity to talk about lifestyle factors and getting herself baby fit before that consultation that she might bring, where she might bring her partner. And, it's important probably to use positive opening statements like, minimal changes in weight have a positive impact on conception, or even minimal amounts of exercise can help. Keeping it positive is important rather than stating the obvious health issues that they might face if they are already overweight. In the scenario where she comes in with her partner, who is 45 years old, and she says, oh, look, we've been trying for 6 months, I need advice, or, well, she might come in on her own, or she might have brought him in with her, and her concern is that he thinks that, they should just keep trying naturally. I explain to her, and if he's present also, that infertility is not just a woman's issue, and that a third of the time the diagnosis is due to female infertility, a third of the time it's linked to male infertility, and in the remaining of cases, infertility is due to a combination of factors from both partners, and in around 20% of couples, the cause can't be determined. So it is important for him to understand that the spectrum of infertility does involve men, and I offer them the opportunity to provide a plan for further chats, further investigation, and when I do have the chance to talk to the male partner and he comes in to talk about their fertility issue, I make an effort there to gain his trust, because I might not be the GP that he has the primary relationship with. The female partner is often the person who has the primary relationship with myself. So I offer him the opportunity to talk about himself and his work and his career aspirations and the amount of travel that he might engage in, what interests he has, whether he goes to the gym and whether or not he takes any supplements at the gym. I take the opportunity to talk about smoking, alcohol and drugs and exercise and previous infections or injuries that might have impacted him or his sperm production. Generally, concerns regarding sperm production and quality in men's eyes have implications regarding their masculinity. So I try to normalise the discussion. I normalise the general examination part of it too, the physical examination, which really does need to be performed, and I include a genital health examination as part of that too. It's important to examine the genital area regardless of age to exclude such things as Klinefelter's syndrome, varicoceles, testicular lesions. And I take the opportunity there to talk casually about screening also for testicular cancer, and that in fact often brings them on board rather than just a discussion about pure semen analysis and quality. And it's, you know, in their mind often the thought is that they might be shooting blanks. So that's a statement that I would never utter. I make comments like, I expect that that's probably what they're thinking, and therefore I make comments such as, you know, did you know that lifestyle has a really big impact on the quality of sperm, and a healthier lifestyle can improve the quality for most men. And I'd like to engage Kate here and invite you, Kate, to talk further about the further investigations and how we can better prepare patients for specialists such as yourself.
Thank you, Magda, and thank you, Louise and Magda, for asking me to be included in this webinar. I'm very pleased to be here. And it is such an important area for patients and practitioners alike to have an awareness of their fertility, and particularly the impact of age, because we think nowadays that everybody knows that as you get older your fertility diminishes significantly. But it's remarkable the number of patients who actually still don't really realise that, and we think that if they have treatment it will improve their chances of success. So I'd like, if I may, to first of all talk about anti-Mullerian hormone, because anti-Mullerian hormone is a test that's done on lots of women, lots of young women, and women in their 30s and early 40s come to their doctors to ask about having a test for how many eggs they've got left. So anti-Mullerian hormone, as you all know, is a marker of ovarian reserve. It's produced by these small follicles, not the tiny primordial follicles, but the next size up follicles. So that's a surrogate marker of how many primordial follicles. And I'm just going to see if I can get the laser pointer to work here. But if you have a look at this graph on the screen, you can see it there. This is a graph of anti-Mullerian hormone levels in women as they get older. And you can see the blue, it was a study, this is a study looking at over 3,200 women. And so the red line gives you the average anti-Mullerian hormone level. It's used, different units are used in this graph to one in Australia, but the point is the same, that we can see that the number of follicles diminishes in the early 30s and then much more precipitously in the 40s. Now, there are a couple of really important things about anti-Mullerian hormone. It is a surrogate marker of how many eggs there are, but it in no way gives you information about the quality of eggs. So we know that if we go on age alone, when we talk to our patients, if a woman comes in at 37, we know that her fertility is a bit less good than it was when she was 25 to 30, that she will have less eggs and she will have a higher percentage of eggs that are chromosomally abnormal. So it just really shows us, this is a visual documentation of the fertility in terms of eggs. Now, the second point about it, though, is if you look at these blue dots, you'll see there's a very wide range. And I think, Magda, you probably have lots of experience with patients coming in having an AMH done that is reported as low. So a woman of 38 will come in and say, look, the GP I went to before you did this test and it says that my ovarian reserve, and what does that mean? It's low. And, you know, you would be saying, well, this is a completely normal situation for your age. It does mean there are less eggs than there were before, but in no way impacts on the chance of you having a baby. It's just a marker of what's going on for the future. And there is such an enormous normal range that we need to be very careful not to overinterpret or misinterpret results. What's really important in a young woman is an AMH of less than 1, a very, very low AMH. That is a significant finding in a woman under 35, because that means that she has got, you know, maybe only a year or two worth of eggs left. If that young woman with an AMH of less than 1 was trying to get pregnant, she would be fine. She has no reduced chance of success at that time, but it means that she really doesn't have a long time ahead of her. In patients with polycystic ovarian syndrome, we do often see an elevated AMH, And it's important not to be overly enthusiastic about this because, of course, if a woman of 40 has a high MH, that means she has lots of eggs, but it still doesn't change the fact that 95% of them, or 90 to 95% of them, are going to be abnormal. So I think anti-Mullerian hormone is sometimes difficult to interpret, and we have to make sure we don't frighten our patients by them misreading the situation. We all know that there is an exponential decline in egg numbers with age, and we know that we have most of the eggs that we're ever going to have halfway through fetal life, and then it goes down after that. And it's very important when we're looking at age to think about egg number and egg quality. I think that's a really important factor. And this graph here looks a bit complicated, but on the left you're talking about we can see the chance of getting pregnant each month. So there's a term called fecundity, which means the chance of getting pregnant each month. And when women are young, it's 25%. It's actually sometimes even higher than that. There is a 25 to 30% chance of getting pregnant for the first 6 months of trying when you're young. But you can see that as you get older, the chance of getting pregnant goes down. And as it goes down, the chance of having a miscarriage goes up. And that is largely related to the age of the eggs and the chromosome normality and abnormality. Over 85% of miscarriages are related to random chromosomal errors. So the miscarriage rate goes up as the fertility rate goes down, overwhelmingly related to the chromosomes, not other factors. So I think it is really important to be getting the message out there about female age and fertility. And another important message is for patients to understand that IVF does not improve on the genetics of your eggs. So we hear often, and you must hear this a lot, Major, patients thinking that if they're 40 or 42, it's okay because IVF will help them to have a baby. And that's true to a degree, but IVF will not improve on egg quality. So I think it's really important to explain that to our patients as well, particularly in the setting of fertility awareness for women who may not even be thinking about conceiving. Now, there was just one other thing I wanted to talk a little bit about, and that's semen analysis, because semen analysis is also very difficult to interpret in a practical sense. And we've all had male patients come in absolutely crushed when they have a minor abnormality on a sperm test that they've been provoked into getting by their girlfriend. So the important parameters in the semen analysis are the sperm concentration and motility. And it's normal to have more than 15 million sperm per mil. Motility is also very, very sensitive to transport and sitting around. So we do see quite a lot more variability in motility than we see in concentration. The other parameter that is documented in semen analysis is the morphology, or the percentage that look normal or abnormal. And that is much less relevant in terms of general fertility. So if a man has a good count and good motility and 97% abnormal forms, that's fine. That's absolutely fine. That would not be having a significant impact on their ability to get pregnant at all. And it's very important because a lot of men will have a high percentage of abnormal forms in the context of normal volume, concentration and motility. And they'd be really, really devastated and worried. And in fact can often get quite depressed about that. You know, men are very sensitive about the semen analysis. So it's important to explain to men that in the context of spontaneous fertility, how the sperm look is very, very, very minor at all. You know, it's really not a significant factor. The other thing I just wanted to say is that when you do find an abnormal semen analysis, it's important to repeat the test, but not for a few weeks, because sperm take over 70 days to develop. So really you want to repeat the sperm test in a couple of months. And it's always fine to just ring up a fertility specialist and have a chat with them about how, if you're having difficulty working out what to say to these patients. So I just wanted to highlight really two important parameters in the primary care setting, mainly age-related fertility and AMH interpretation, and also semen analysis. So they're really the main things that I wanted to focus on tonight.
Right, thanks, Kate.
Kate talked about investigations. Do you want to just briefly tell us about the treatment options available?
Yeah, so when a patient is referred for fertility assistance from the primary care practitioner, and the primary care practitioner has already talked to patients about lifestyle optimisation and making sure you're as healthy as possible, there are lots of different options to look at in terms of optimising fertility. Naturopathy and acupuncture are complementary therapies that have been shown to optimise general health and well-being, and may have a role in general fertility. There are no large randomised studies confirming benefit in specific fertility parameters, but I think that they also help patients with their overall well-being and resilience. If a patient is not ovulating very well, we can use ovulatory stimulants, tablets or injections, and sometimes surgery is required if there is a mechanical blockage that can be fixed. In young couples who have infertility of relatively minor, brief duration, we can contemplate artificial insemination, which really just gives a gentle little boost. We use low-dose hormone injections to optimise ovulation, and then artificial insemination. And then there's fertility treatment such as IVF, where we're actually taking the eggs out after stimulation and making embryo. And nowadays IVF is extremely successful treatment, extremely successful. But of course, as a woman gets older, the chances diminish. So these are the options available for patients. And it's important to know that there are a range of options, and patients, when they're referred, are not necessarily going to be rushed into IVF. So over to you, Louise.
Thanks very much, Magda and Kate, for this discussion. We have invited you to ask questions, and there's been some questions that come up, but there haven't been some themes that have come through your questions. But please, as we're completing the seminar in the next couple of minutes, if there are questions, please post them online, and we'll develop a question and answer information sheet that we can distribute to participants. Again, thank you to our speakers, Magda and Kate, for your participation this evening. We've run out of time, but you might find some resources of interest on the Your Fertility website, www.yourfertility.org.au, under the section called For Professionals. For instance, there's a link to the Think GP model, and you can earn CPD points while learning more on the topic. There's an Optimising Patient Fertility video featuring Kate and presented by Dr. Carolyn West, which expands on tonight's discussion. There's also a range of resources that you can use with your patients, including evidence-based fact sheets on the factors that affect fertility, developed in association with the Fertility Society of Australia, and much, much more. So please don't forget to complete your survey. Your feedback is really important to us. And thanks again, and good night. Thank you very much.
Good night. Thanks, Louise.
Good night.
Thanks,
Thank you.
Kate.
Bye.
Bye.